I farmaci anti-CD38, i due attualmente disponibili, che sono il daratumumab e l'isatuximab, sono due farmaci fondamentali per la cura del mieloma multiplo. Noi ci siamo fatti spiegare quando utilizzarli, ovvero in quali fasi di malattia, come utilizzarli, se utilizzarli da soli oppure in associazione, da un vero esperto, dal professor Xavier Leleu, che abbiamo incontrato qui a Bergamo nell'ambito di un meeting che ha fatto il punto proprio sul CD38 e che è stato organizzato da SOHO Italy. Professor Leleu, in which stage of the disease of multiple myeloma it's best to use anti-CD38 drugs?
So excellent question. So in myeloma, we always start to develop drugs in end-stage myeloma. And if it works, we try to bring that drug in earlier stages. Now, we now have data of the use of anti-CD38, CD38 antibody upfront in newly diagnosed myeloma. And it seems to be so active that the simple answer to your question is as early as possible when you diagnose a patient, upfront would be better probably.
And how to use them? Which dosages, and alone or in combination with other products?
Two questions. Two answers. Number one, the dose is the recommended dose. For the first one, daratumumab, subcutaneous use, fixed dose, so it cannot be more simpler. For isatuximab IV, and tomorrow for isatuximab in its subcutaneous version, it will be also a fixed dose. So the dose is simple. It's a fixed dose for all patients. So no headache with the question of dose. The notion of combination is more something to discuss. I agree with you. We know that CD38 antibodies, the two of them, isatuximab and daratumumab, they have a very strong, powerful, synergistic combination effect with the immunomodulators drugs family, lenalidomide, pomalidomide. But in recent years, we have learned that the combination to proteasome inhibitors, bortezomib, carfilzomib, even ixazomib, could be actually extremely active and of great benefit. Guess what? In the future, we may see actually an all-in situation where CD38 monoclonal antibodies will be combined to proteasome inhibitors and lenalidomide and dexamethasone. Professor Paul Richardson here discussed the quad drug-based regimens that are probably going to be the standard of care in young transplant-eligible, but also more elderly non-transplant-eligible patients in the future.
And which is the clinical benefit of these two drugs?
Well, numbers, to answer your question, I guess numbers. In the study called Maya, patients that could not receive a transplant upfront, could not receive an autologous transplantation upfront. The median survival without relapse, without death because of myeloma, was 5 years, 62 months, meaning that half of the patients will not relapse and not die because of this sad disease, even in more than 5 years. And that we have never seen before. In transplant-eligible patients, younger, we hit a level of 50 to 70% of the patients that have what we call MD, minimal residual disease negative status at 10 to minus 5, after 4 or 6 cycles. Only after 4 or 6 months, 4 or 6 cycles of anti-CD38, proteasome inhibitors, immunomodulator drugs, and dexamethasone, 50 to 70% of the patients are MD negative. So these numbers are numbers, but what they tell you is that the addition of the CD38 antibody to whatever regimen we had before not only had improved, but gigantically improved, actually.
And how long to use them?
Yeah, that's maybe the limitation. Right now, the feeling is that if you use these drugs, you have to use them constantly, continuously. And
until relapse.
Yeah, sort of. As a patient, I'm not a patient, but if I were a patient, I would not like it. Because in one hand, and we discussed this in the meeting here with Claudio, Flavio, and all these CD38 experts and CD38 therapeutic use physician experts, that we need to find a way to use the CD38 antibodies for fixed duration. Right now, we give it continuously. Maybe in the future, we'll look into fixed duration for the patients.
Professor Leleu, there is a winner in this competition within these two drugs?
Dangerous question. I'm going to give you a fun answer. Yes, there is a winner. The winner is the patient. The winner is probably the physician. But if your question was whether we clinicians have seen a difference across isatuximab, one hand, daratumumab, the other hand, I would say probably no. I mean, I like using the two drugs. I think the two drugs are great. The availability of isatuximab subcutaneously with this new device, OBDS, is going to be a great addition to the armamentarium we have. And so to me, there is a winner. The winner is the patient and their families. Thank you.